Ms. Jessica Tan.
Thank you, Mr. Speaker. I thank our Minister as well as SMS for the comprehensive reply, as well as the reassurance that we will continue to improve. That we will continue to improve the processes and measures. I'd like to ask two supplementary questions. With the increase in cases and the home recovery as the default care management measure for COVID positive cases, there's no discharge memo that will be given after they have recovered, after the 10 days. So what help can individuals get in terms of getting their trace together status cleared? Because I've got quite a few requests for help, because many have got their trace together as still indicating that they're not cleared, and they cannot proceed on to even just do daily necessary activities. The second supplementary question is that for seniors that are sent to the CCF, what is the support given, especially those who are not so digitally savvy and they need help at the center because they are alone, they are not able to be accompanied, and several of them may be over 80. Because I also had several requests for help because some of the seniors didn't know what to do and even how to ask for help or use some of the simple facilities. Thank you.
Thank the member for raising this issue. Indeed, I have a lot of feedback too, where a person after his discharge doesn't have his TT indication lifted. So we are fixing that. It's essentially an IT problem. The reason why there's now a fixed day of discharge, because once a person is vaccinated, actually viral load drops very quickly, especially after day 5. And by day 10, pretty much you can't culture. NCID find that they can't culture the virus anymore because viral load becomes quite low, which is why we can safely discharge patients who are vaccinated at day 10. IT system need to keep up with that policy. So in the next few days, the TT token issue will be resolved, as we will also synchronize the removal of the alert in line with the discharge day. Yeah. So once you are infected, TT token your TT app will know, and it will count at 10 days from then. If you are vaccinated, it will be automatically removed. If you are not vaccinated, you'll be removed after 14 days. So this problem, I expect it to be resolved sometime this week. As for CCF, thank you for raising that issue. There are nurses and there are workers available at the CCF facility. So if we come across such cases and the senior is alone or illiterate, let us know, and we will alert the CCF facilities, and there are people on hand, medical workers, who can help out and help the senior navigate and understand the messages that we are sending to them.
Ms. Dinispoa. Please limit to 2 SQs if possible. Keep the questions short. But this applies to everyone.
Thank you, Minister and SMS, for the answer. I know it's really a very difficult time for everyone, and so we also want to support as much as possible, but I can't help asking these 2 supplementary questions. Number 1 is, thank you for letting us know that home recovery now is a default option for PCR or COVID positive residents. I want to know, my questions are specifically for those who are vulnerable. What if home recovery is the default option, and what if one's resident is just not suitable? For example, some of us, especially in the Central District, we have a lot of rental flats, and there's a lot of sharing of facilities like toilets and living room, and just one door, for everybody to just move into. So what if the homes are just not suitable for home recovery? Or what if there are just very large families in some of these homes? Number 1. Number 2 is, thank you also for making it very clear SMS, Janil, that caregivers are allowed to accompany those who are vulnerable, like the elderly, who are not independent, the disabled, young or old, and so forth. So it's how as MPs, we often get questions that are fast and furious, and if they come to us, I think if we write to MOH, POHs, they're always very responsive. But in general, how does the public get to know, that the caregivers can accompany the more vulnerable, and that, especially if the MOH hotline is very stretched at the moment. So what if quick responses are required, and
you can keep
members
your
of public
questions short,
just
please.
don't know where to get the answers? Thank you.
I will keep my answer short.
Thank you.
HRP is the default provided you meet certain criteria, such as you are younger, you are vaccinated, some not vaccinated but younger too. And therefore, but within this default, while it is the default, it is not rigid. It is important that once a person is notified that he's on HRP, he's also given a phone number to call, what we call a HRP buddy. And if he's not comfortable because of living conditions, or he's living with a vulnerable senior, or children unvaccinated, they can then make the request to say, while I'm asked to go on HRP, can I be taken up to a CCF? And we will try our best to accommodate those requests. So your residents can certainly request by calling the HR buddy. As for how will the public know, mass media is one way. We put out FAQs as simply as we can, but even so, it's hard to understand by many members of the public. Another layer will be our community volunteers, our CCs. Many do call up our CCs to ask questions. And so we also need to arm PA and our community centers with all these questions. And really there's a Pareto relationship. Most of 80% of the questions are related to that few things. Yeah. And our volunteers should be also equipped with those information, and they can reach out and explain to them. Finally will be the hotline. I think it is true, the hotline has been difficult to call through in the past few days, but we've been beefing up the resources day by day. With the SAF's help, it has really improved a lot. As of yesterday, when I checked, we are able to pick up almost 70% on the phone calls. So it is improving, and we continue to improve. And once that happens, as more people can call through, get the answers, they will also tell their friends, and I think the situation will change.
Associate Professor James Lim.
Thank you, Mr. Speaker, and thank you to SMS Janil for his responses. Both my supplementary questions have to do with whether we are following protocol that may look good on the surface, but actually seem to make less sense when you dig into the policy. The first has to do with my question on what the material differences between importing cases and quarantine. If I may develop this, it is the risk, the concern, the risk of importing new variants? And if so, does MOFM actually have a view on risks of the new variant's fitness, given that Delta is fairly endemic? Does it make sense to apply such a strict protocol that could discourage business travel with long stay-at-home requirements for imported cases? My second question has to do with how SMS indicated that currently those issued with a quarantine order should self-isolate, but it actually doesn't require all family members to do so. I wonder if SMS has a view on how this procedure could potentially be a loophole, since surely there's no appreciable difference between the legal guardian that has to accompany a minor in the case of an SHN versus the other household members, insofar as virus exposure is concerned.
So I thank the member for his questions. I think for the first question, I think he's essentially asking why does it appear as if there are different standards for someone who's traveling versus someone who's given a home quarantine order or a high-risk alert here in Singapore. Well, partly this is as a result of the changing situation. And actually today an increasing number of travelers are allowed to do a stay-at-home notice. And you will see that we will have further and further streamlining, optimizing, and alignment of our various measures. And the situation is moving quite fast. We will review and align these measures. But if I could go into the specifics of his question, or at least what I think are the specifics of his question, the risk associated with travelers is partly to do with variants. It's partly to do with the robustness of the information that we are receiving, depending on where they're coming from, what we understand about the situation they have in their home country, as well as the particulars of that individual's likely location if they are not in a dedicated facility here in the stay-at-home facility. So we do take all these factors into account when dealing with the appeals with respect to travelers. For his second question, if I didn't quite understand what he was asking. The call is for all of us to be responsible and for the household members of a contact indeed to register. We're not asking for only some of them to register, we're asking for all of them to register. And indeed the risk to the whole household is pretty much the same as a caregiver that accompanies someone who is vulnerable. Hence our request for all of them to register. And in truth, much of the exposure and the risk will happen before the COVID-19 index case is detected. Hence, that's why we're requiring the whole household to limit their movement and their exposure to people outside of the household. Thank you, sir.
See upon wing.
Thank you, Mr. Speaker, and I thank the Minister and the SMS for their replies. I have two SQs. The first pertains to question 2. The COVID SITREP website is a good initiative in terms of communications. I wish to ask whether the Ministry is prepared to consider benchmarks such as the probability and death rate of getting the seasonal flu and dengue fever versus getting COVID in our public comms. This will help allay fears and contextualize the likelihood of getting COVID-19. My next SQ pertains to question 12. In monitoring the COVID situation in Singapore, I wish to ask the Ministry what are the next trigger points that MOH is worried about, and given the R0 indicator, we can roughly predict when they will occur. As such, how does MOH intend to communicate both the trigger points as well as the time horizon to the public? This will give the public and industries sufficient lead time and early warning to adjust to new measures. Thank you.
Sir, I'll address the member's first question. Indeed, we do need to communicate the relative risks of COVID-19 infection, getting the infection, and then perhaps risks of complications and severe disease, and put these in context relative to other common diseases such as influenza, or even not so common diseases such as dengue, for the public to understand how they should go about their business when we reach some sort of equilibrium. And we will be putting more information out into the public. But at the moment, we haven't reached that equilibrium yet. And we're in the middle of quite a large wave. And there are very real anxieties around COVID-19. And I think especially for the elderly, the vulnerable, the under-vaccinated. So I thank the member for his suggestion that we do need to put some of these numbers in the context of a lot of other diseases that we're used to dealing with, and we will do so when we are approaching an equilibrium, and we have plans to do so. But I think at the moment, the anxieties are around the large number of cases, the wave that we're experiencing. It's very real, and we shouldn't underplay it. I understand Minister Ong Ye Kung will address the second question.
Thank you. As for the member's second question on trigger points, before we loosen our safe management measures further, we are aware, and we are all well aware that certain countries have declared certain dates or certain vaccination level, and then they will open up this and that. They have adopted that approach, and we have by and large not adopted that approach because we recognize that in battling COVID-19, this is a live, evolving, fast-changing situation. And it is not wise for us to tie our hands and limit our options as we adapt and stay agile in battling the COVID-19 virus. And therefore, we will have to take into account of the situation in hospitals, our case numbers, how people are reacting, what is the social circumstances, our social preparedness to live with the virus. Take all this into account, and also businesses, how they are doing, and we adjust our measures time to time. But our direction is very clear. We have to live with COVID. We have to become a COVID-19 resilient nation, and the direction is clear, but from time to time, we may take a longer route, we may take a detour, but stay on course.
Mr. Jerogan.
So my first SQ is for Minister Ong and my second is for SMS Janil. So many Singaporeans and businesses are very frustrated with the repeated open shut of our economy and our lives. Minister Ong said on 21st September that during the preparatory period, MOH projected handling 100 to 200 cases a day. This is far lower than the actual caseload since 19 August. Why were these projections so far off? Delta has been with us for almost 6 months, and there's plenty of data on Delta infections from countries like India and Israel, which were hit by the Delta wave before us. Why wasn't the government better prepared for the caseload after reopening? And for SMS Janil, what is the rationale for children under 12 being ineligible for home recovery, given that children, even those unvaccinated, usually have mild or no symptoms when infected? Because allowing them to recover at home by default allows their parents to care for them and will also reduce the load on hospitals. Thank you.
I'll answer both. I don't think we characterize our safe management posture as opening, shutting. But depending on the situation, we have to make adjustments, and we have made progress in the sense that I think we have put circuit breaker behind us, where if we remember in April last year, almost all businesses are shut down. And then we have heightened alert, which is a far more moderate form of slowing transmission, slowing economic activities. This time round, we try not to go back to heightened alert, but instead, it's mainly restaurants and F&B that are affected, but we want to keep them open, try not to affect businesses so much. MOF provided financial assistance, but they can operate with table of two. So I think we are making those progress, and I think we should also feel encouraged that because of vaccinations, we are able to move forward. As for the numbers, if I remember correctly, late August, when we start seeing a wave, I mentioned 3,200 as a possible daily number, because if it multiplies or doubles, if the doubling cycle goes on 5 times, we were at 100 then. If it goes on 5 times, we would have reached 3,200. The 100 and 200 number, I'm not sure where it come from. A lot of things were said during the MTF, but I did refer to it as during the preparatory phase, we were hoping to maintain around that number because we are still preparing ourselves. And when the whole thing is over, on the endemic stage, perhaps we will see 200 cases, maybe more. But I hope we take all these numbers in the spirit. I speak to epidemiologists, doctors all the time. They give me all kinds of numbers. I try to explain things to the public. And so some numbers may be picked on, but let's take it in the right spirit. I'm not making any projections or predictions, but these are things that I learned from MOH, and I'm trying to explain to the public to the best of my abilities. As for children under 12, actually they can serve home recovery. And we do encourage them to serve home recovery. And many parents, in fact, like to serve home recovery. So we pretty much encourage that as well. I'm not sure if it's made the default, but certainly it has great potential to be made a default, and great majority of children can recover very well at home, and they are happier that way. Yeah.
Ms. Joan Pereira.
Thanks, Speaker. SMS mentioned that MOH has tapped on private hospitals to alleviate the load on public hospitals. I have one SQ. May I know how has this helped alleviate any shortage of resources in the public hospitals? I have had residents who have been hospitalized with non-COVID related illnesses and shared that the care was inadequate. So I hope SMS can answer that. Thank you.
Sir, I thank the member for the question. The whole of our healthcare system has been mobilized for this effort, public and private, and they are different institutions, but they are working as a team. It's a bit hard to quantify because the private sector is looking after COVID-19 patients under their roof, as it were, but they're also looking after other patients with the other conditions. Their doctors and nurses have been deployed elsewhere into other sites. So has it helped? The answer is yes, because manpower is available, beds are available, resources are available. But to put a specific quantification on it, I don't think I'm able to adequately answer the member's question. The way I would look at it is this: we have a healthcare system here in Singapore that is made up of public providers, private providers, volunteers as well, and the healthcare isn't just about the bed, the doctor or the nurse, it's the entire system working together, and everyone is mobilized to try to do their best to deal with this crisis in front of us. So I suppose the shortest answer to the member's question is yes.
Mr. Liang Eng Hua.
Thank you, sir. I would like to ask the Minister of SMS on those that need to do the 14-day mandatory PCR test. MOH currently runs about 8 publicly run regional PCR screening centers, and they are not quite located at the convenient locations for those who need to do those tests on a weekly basis or bi-weekly basis. So can I ask the MOH if there are plans to build more of such centers? Secondly, in some estates where there are hawker centers, they do have their own PCR testing facilities set up, but they are only only the storeholders are allowed to use those use those testing facilities. So in such situations, can I ask if MOH can allow or support or facilitate this PCR testing facility to be used by other workers as well who need to do those regular 7 days, 14 days tests, so that the community resources can be shared and better convenience for those workers, the frontline workers, as well as the building that community spirit as well. Thank you, sir.
So I thank the member for his question, and he has identified the direction in which we are moving with these strategies. We've opened up more centers. We have actually 22 regional swab centers, 20 quick test centers, and 5 private quick test centers. And we're already working on opening up these areas to other users, working with the employers as well, just to make sure these resources are made available to as wide a base as possible to speed up the processes that he talks about. But sector leads, the employers, within the employers, they're encouraged to move towards the fast and easy testing RRT, primarily with the employer-supervised self-swab model, so that people self-test at their own location, at their own convenience. Some sectors will still keep going with the quick test centers, and the ones particularly in the hawker centers that the member talked about are available, but they're prioritized then on the basis of how they were set up for the employees that they are meant to serve. But in the medium term, we're working with other parts of government to incentivize private vendors, perhaps through a grant scheme. And our intent is to then set up more centers which can be more convenient in other locations for the community and larger groups of workers. This is an important part of our strategy going forward for COVID-19 resilience. Thank you, sir.
Ms. Herting-Ru.
Thank you, Mr. Speaker. I have two supplementary questions. The first is I take Minister of Health's earlier explanation about the numbers that were quoted earlier. But I think my question relates to what were the previous planning parameters when we first started deciding that, when we first announced that we're moving into an endemic phase? Because, that this is very key, because we need to know that we are properly resourced. We don't have a situation like, we saw in the last couple of weeks where people were waiting for days and, up to a week before they were actually responded to. So my question would be, how many cases were we planning for back then, before this current surge? Was it 1,000, 2,000, 3,000, 5,000? And, how can we actually put in measures in place to make sure that it doesn't occur, especially, we are planning to really loosen the restrictions again in 3 weeks. So, I think everybody want to avoid a situation where we actually end up where, every time we loosen some restrictions, we see a massive surge and then people cannot actually get any answers and they cannot get through on the hotlines. And the second point is whether anything can be done for better communications and messaging for residents and people who are actually affected. Because, we have things like heightened alert, stabilization, preparatory stages. People are getting very confused about what each of these actually refer to. Same like the acronyms like HRP, QOs. And I'm sure that many members have actually seen this many different flow charts, spreadsheets, It's just very, very confusing. And I think, what else can be done to make sure that our communications to a very complicated situation is communicated to residents so that, they don't end up having to jam the hotlines as well.
I thank the member for acknowledging that it is a complicated situation. And over 20 months, we have developed many responses, many protocols, in order to respond, in order to handle the situation, which is why there's now a plethora of different protocols. But as I mentioned during our press conference over the weekend, now we are in a different phase. Many of the protocols were designed at a time when the public wants to see us snubbing up every single cluster. And so we have all these tight protocols. But now we are in a phase of trying to live with COVID-19, and there's a proliferation of protocols. And so we announced last weekend that we are in the process of holistically reviewing all the protocols with a view to streamline them. I don't think we can get away with some abbreviations and some alphabet soup that will still be around. It is, after all, a very complicated situation. But we'll try our best to streamline as much as possible so that people will understand it, able to do their part to fight against COVID-19 and also to help others. But back to the numbers and planning criteria, the members seem to have a narrative that we were totally did not plan for all this. Far from the contrary. On the contrary, we have always planned for a big surge. You would hear from Salisbury Hawk School, and these are partners that we work very closely with. They have projected 5,000 to 10,000 cases a day, as high as that. You speak to different epidemiologists, they may have different views, but these are the numbers if we fully open. And you've seen it in other countries happening, that kind of peak. And that's why through our communication with public, you will hear us, whether myself, Minister Gan or Minister Lawrence Wong, always saying cases will rise. When cases rise, number of people with severe illnesses and deaths will rise. And we've been saying that. And I also mentioned at end August, when we start to see the start of this wave, we say that doubling cycle, if it happens 5 times, we will reach 3,002. And therefore, we have always sized ourselves up for that kind of number. And we hope that we can do so progressively and not suddenly, which is why we also announced a 4-stage opening process. Preparatory stage, where we try out home recovery, build up our CTFs, CCFs, and so on. And then transitions, we call it transition stage 1, if people still remember, then stage 2, and then finally endemicity. We gave no deadline or timeline for reasons I explained earlier that we need to watch the situation. But we were just in the preparatory stage. The Delta variant came in, and then cases start to shoot up. But fortunately, we have always been planning ahead, which is why at that point in time, we were already ready to handle 1,500 cases a day in terms of CCFs, hospital beds, ICU beds, and then also thinking already about setting up the CTF beds. And we are also starting with the HRP. And by now, we have capacity to handle 3,000 cases and ramping up in a week or so, 1 to 2 weeks, to handle 5,000 cases, but we don't know whether we'll reach there. And then already thinking about the next step, how to handle 10,000 cases. So in terms of planning, capacity, manpower, we always 1-2 bounds ahead. What I think did not go well, and I fully acknowledge that, was the HRP. And all the complaints about conveyancing, calling, not getting in, people not getting responses, is not because the beds were totally full, but processes with regard to the HRP was not totally ready. And we were caught by the sudden increase. We were still implementing a pilot program when all this happened. But the team swung into action. The call of public duty kicked in, and everybody is putting heart and soul, solving the problem. So day by day, we are seeing improvements, and we'll continue to do so. We have to make HRP work. Then, the great majority of patients who are well, no symptoms, mild symptoms, can recover at home. Then the hospital capacity that we plan for can focus on the 2% that really need help. Things are improving.
Mr. Seah Yao Chuan.
Thank you. Thank you, Mr. Speaker. My question pertains to my original PQ 18 Part B, which I believe has not been quite answered. And the question really is this: as we learn to live with COVID and as we settle into a new equilibrium of elevated daily number of cases, in the longer run, what is the capacity of general wards in public hospitals that the ministry expects to set aside for COVID-19 patients? And the concern is the more beds we set aside for COVID patients, I think the less beds we have for non-COVID related conditions. And are there enough hospital beds to go around in our public healthcare system? And the other side of this question really is in terms of wait time to a hospital bed for a COVID-19 patient. In the longer run, at steady state, does ministry have an expectation, and what might that be? Thank you.
I thank the member for the question. Questions, I beg your pardon. For the first part, we set aside COVID-19 beds currently because our approach is to isolate them and separate them from the rest of the patients, rest of the healthcare facilities. But as you go towards endemic COVID, COVID-19 will have to be treated like any other infectious disease. And in peacetime, in endemic situation, we don't have influenza beds or dengue beds or chickenpox beds, and all of these are infectious diseases. What we have is beds on the basis of the patient needs. And increasingly, the COVID-19 patients in hospital will have other types of needs. They will have kidney problems and heart problems and neurological problems. So it's a bit hard to then delineate in the steady state, once we're done with the surge, once we're done with this current strategies as we move towards endemic COVID, I don't think we'll be in a position to then say these are the COVID beds and these are the non-COVID beds. We will have to treat COVID-19 like other infectious diseases. But nevertheless, in the middle of the surge now, we are ramping up our capacity, mobilizing resources as we've described in our answers to the PQs and the SQs, but also trying to improve the flow of patients through our system so that these resources are made available. But the most important strategy is to focus the resources that we do have on those who need it the most. And vaccination is part of reducing the number of people who need those resources. The well, who are asymptomatic, being able to stay home or go to CCFs and CTFs is part of that strategy as well, as are our attempts to then slow down the transmission in the community. And all of this then feeds into the issue of wait time, whether it's about a bed space or having your call answered, making sure that those resources that we have and those officers are deployed to deal with the people who need help most will also help in reducing the wait time, but ultimately we do need the manpower, and we are working on ramping up that capacity as well. Thank you, sir.